Good morning, everyone. You are welcome to the third edition of the EUROSON POCUS School, Vienna 2022. It's a real pleasure to be together with you in this nice morning. And I want to welcome you. And also, I want to thanks to all the participants. I want to thanks to our keynote speakers, Professor Shlomo Winker, who is the president of WONCA Europe, and the second keynote speaker, Professor Christian Janssen. He is the president of European Federation of Ultrasound in Medicine and Biology. And also to all our speakers who are together with us, training us, and also to all the participants who are in such a great number. And I want to make a short briefing about what we discussed yesterday. It was a very interesting day, a very comprehensive day with a lot of presentation. And we're starting with the new concept of the clinical ultrasound examination. The speaker was President, the Professor Shlomo Winker. And then we have some standardized plans for the daily practice of clinical ultrasound and the PoCUS application in family medicine by me. Also, there was the nice presentation of the syndrome focus ultrasonography by Dr. Mateusz Koziak, who is the co-founder of EUROSON Poland. And also, we had the introduction of ultrasonography-based elastography by Professor Vito Cantisani, the Fsum honorary treasurer. And also, we have a very nice presentation with the role of the artificial intelligence in the complex evaluation of patients with liver steatosis by Professor Adrian Săftoiu, the past president of European Federation. Then we go on with the multi-parametric ultrasound in hepatology by Professor Ioan Sporia, and the nice presentation of the Professor Christian Janssen, who was the keynote speaker, the simple ultrasound guide-based bedside intervention. And the Dr. Gergely Agoston, who is the vice president of Hungarian Association of Cardiovascular Imaging, make a presentation about the focus or rapid cardiac assessment. Professor Dana Stoyan make a very nice introduction to the thyroid clinical ultrasound, and then the Professor Dominic Camille make the presentation of introduction to the breast ductal echography concept. Then we have a very interesting presentation from Tel Aviv with the case recording of the artificial intelligence capability to diagnose the cardiac problems in the primary health care. Thank you, you are all, for this first day, who was a successful day. And the second day, we starting with the theoretical presentation, and then we will have a roundtable with the theme, the future of the using point of care ultrasonography in ambulatory healthcare from the perspective of professional organization named WONCA Europe, European Federation of Ultrasound in Medicine and Biology, World Federation of Ultrasound in Medicine and Biology, and EUVECUS. Our invited speaker, you know now, and all our keynote speakers and speakers are invited to this round table. Then we will have the workshops with the hands-on session, and all the participants, it's a must put the hand in the hands-on session, the probe of the ultrasound and to the patient, because we have 8 units, and you can use all these 8 units to try to make the ultrasound examination end today. Thank you, dear participants. And then we will have the final evaluation of the participants, with the awards of the certificates of participants of these certificates. One is Fsum endorsed, and another is with 16 EACCME credits. And for those who want to participate to the gala dinner, you will transport it by a private bus from the front of the Universitat Sun Clinic, leaving at 7:15 to the restaurant Zeiler der Heurige, returning, and I think to 12 o'clock. Thank you, and I wish you luck, and I wish you to have a good day. Thank you very much.
At the beginning, I want to thank Dr. Michael Jakob for organizing this pretty conference the third time, and I'm very gratified to be able to speak here. And from my point of view, I will give you aspects, clinical, practical aspects of the work in general medicine. Ich kann diese Präsentation runterlegen und kann meine aufmachen. Gell? It is here. So. Ja, focus in general medicine. I'm a practitioner, so I'll show you how to implement sonography in the daily routine. This is the area I'm working. It is in South Styria, and this is my team. I'm the owner of a single-handed practice. I have a private practice with contracts to all state insurance companies, so people need not to pay if they come to me. It is all done by state insurance. And this is the first picture which I think can show you an important detail. This is my working place. And you see, near the desk where I write and have the documentation with the computer, near the chair where the patient sits, nearby, close to this working place, stands the ultrasound machine. You see, there is no delay in time, no delay in space. Thank you very much. So if the pictures are brighter now, there is no delay. I talk to the patient, I do the physical examination, and at the same time I already start the sonography. So sonography is not done somewhere but here. It is not done sometime but now, and it is not done by somebody but by me. And this means point of care sonography. This term of PoCUS is a very coming term now, and we have to use it for our work. I've told you about my practice, my surgery, it's not too big but not too small. So and I can tell you, every day about 100 patients enter my house, enter my surgery, my practice. And you will think, for the young colleagues, 100 patients a day, crazy, how to manage it. And I say, thanks God, because I get paid for 100 patients. But I'm also lucky, because only 30 of them I see face to face. And from these patients, approximately 5 patients a day need an impactful medical decision from me. So you see approximately 5 patients, this is manageable. So this is the job in general medicine at all, to filter these patients who need critical, accurate, impactful decisions. And how we do this? How we do it anyway in general medicine? We talk to the patient, or better, not talk, we hear to the patient. We sit together and get an impression. We do the physical examination. And out of this, we derive a further clinical issue. And now sonography can help us to form yes-no questions and to interpret these sonographic findings in their clinical context. This is the way we work. Every patient we work every day. That's the way of working in general medicine at all. And talking about these clinical decisions, these impactful decisions, you have to do it anyway. Patient with dyspnea, patient with swollen legs, you have to make the decisions. And sonography can help you. Sonography is not a burden, a work to do in addition. No, it helps you to make this decision. You have to do anyway in every patient, every day, and several times every day. As you have seen yesterday already, and I want to focus again on this topic, there are different sonographic objectives. In general medicine, we are searching for swift answers to medically relevant yes-no questions. So, as you give you examples afterwards, the radiologist or the various organ specialists, they perform in-depth sonography examination, entire organ clarification. So the radiologist has a different job than me. I have a clinical question and I want to try to form it in a yes, no, and to go on with my treatment, with my process. The radiologist, he has to say a total entire organ clarification. And so PoCUS is not a contrahand to any other discipline. It is not a replacement for a formal ultrasound examination or screening. So these are two different approaches, and we have to be aware that it's the same machine but different objectives in going to the work. Now, having a look what of point of care ultrasound can be used for in general medicine, we can have a focused view on clinical exam, physical exam. We can, as we saw it yesterday in the presentation of Professor Jensen, we can guide the procedure. We can have a focused diagnostic on an organ, or we can have multi-organ scans, as we heard yesterday from colleague Dr. Kosiak, the focused, syndrome focused. We could look at the syndrome and try to find approaches with sonography to clear up this syndrome. These are the theoretical possibilities how to use sonography. It's an overview, we could say. And now I have prepared for you such clinical situations from my daily work, and I try to form these yes-no distinctions, these yes-no questions, and I've prepared it like a quiz for you. So you for yourself can say yes or no, and especially of those of you who are not so experienced in sonography, try to find your solution now. And you will see, if you know anatomy, you are not so far in the ability to say, oh, yes or no, and the learning curve is very steep sometimes. So I invite you to go with me into this quiz, and we have on the left side, and we have on the a video loop on the left side, and a still picture on the right side. Mainly the loops are from my machine, and the other ones I had to add and give the source also. So look at the picture, look at the loop on the left side. You see, yes, the patient has a gallbladder. Not every patient has one. Many of them have already cholecystectomia. So you will search and search, you find, and then you talk to the patient and say, "Do you have a gallbladder?" "No, I have been operated." "Okay, thank you." But he has one, and you see something in it, and you see also a shadow after the above, no, not above, under the stone. So we can say yes, he has a gallbladder and he has stones, and on the left side, no, the gallbladder is empty. Next big and very frequent question is the urinary bladder. Is it full? Does the patient have urine? He cannot void the bladder. But you see, it is very easy. The urinary bladder is full, okay? And this examination, of course, can very well done bedside. In addition to my working place, I want to tell you I have 2 more investigation rooms in my clinic. In the next one, a resident works, and in every of these rooms there are handheld devices, and also in my car, this is my 4th device in my practice. Also in my car I have this handheld device. So visitation in the nursery home, home visit, patient has urine, has no urine. Okay, it's a very, it takes me seconds, not minutes. Okay. The next question, an important question. Left side movie loop, right side still picture. Is the renal pelvis congested? You can consider that in every urinary tract infection with fever, with high inflammatory signs, it is a very important distinction who is a patient severe sick, needs to be referred to the urologic department, and who has a simple infection of the urinary tract. So I think you have made your decision. On the left side we can say, who says yes on the left side, the pelvis is congested? There are some hands. Okay, yes. Okay, it's okay. On the right side, no, that's a normal kidney. Free abdominal fluid. The patient comes and says, my stomach is growing, I have to make diet. Yesterday evening we ate so much in the restaurant, so why is my stomach growing and getting big? Okay, so, and we say, oh, let's have a sonography, and you see on the left side the urinary bladder, and above the urinary bladder there is liquid. On the right side you also see moving bowel, moving filled bowel, so there is also a bowel, but there is no fluid in between. So we have free abdominal fluid on the left side and none on the right side. The next question, spleen, visible, still picture on the left side, loop on the right side. This picture, this comparison of these two pictures may mislead you, because on the left side the depth of entrance is not so big as on the right side. So they seem similar big, these two spleens. But if you look on the right side, like Mikhail Jakob said yesterday, look at the comparison from the kidney to the spleen. On the left side it is the kidney and the spleen are on the same level, and on the right side spleen is much more big, and you can measure it. Of course, here is also an additional. Do we see the cursor? No, we do not see it. Okay. On the left side, on your right side, you also see an additional spleen, big spleen. Okay, and we have to find the reasons. So, yes, it is of normal size. Right side, no, it's bigger. It's not bigger. Intrauterine content, young women, also older women, middle-aged women. She doesn't expect that there is any content in the uterus. So we have every cases of lower abdominal pain. We have to look at the genitals, inner genitals, and on the left side you see there is a small cavum, not too much, but it is, you still do not see the heart beating, but there is something. On the right side you see endometrium, big, perhaps it may be premenstrual, so the bleeding will be soon, I can imagine seeing this, but there is nothing inside the uterine. So yes, there is a content, no, there is none. Next big question, dilated abdominal aorta, more than 3.5 centimeters. It's clear on the left side and pretty small abdominal aorta on the right side. And then in my daily work, a very common, very frequent situation. You know, our population grows older. People get heart failure, cardiac decompensation. We have a lot of cases in the nursery home. That's my daily work. So we have to see, we have to look about the pleural situation and the lung situation. And on the left side, for those of you who are not so experienced, you see the diaphragm, and above the diaphragm on the left side there is fluid, reflexless area fluid, and on the left side, on the right side, excuse me, you see, you have a pointer. Oh, but I would like to, but I explain in words. On the right side, you see also. Thank you very much. Oh, fine, thank you. This is the diaphragm. This is, and above it is free fluid. This is the spleen. This is the spleen, and above the spleen there is air. There is air. So there is no fluid in between the spleen and the lung. So we have pleural effusion. None. So we get that we have yes on the left side and none of the right side. And the same with interstitial lung fluid. If there is air only in the lung, so you have only artifacts, reverberation, as you see them horizontal lines, A lines. We heard it yesterday, very fine. Or on the left side, B lines, the vertical comet-like lines. So we know there is something in the lung. Mostly it can be fluid or an infiltration. Now you see it. Now both loops are running. Yes, there is interstitial lung fluid. Right side, no. Now there is a little bit a tricky and not so easy distinction, because it is more seldom in general medicine. The pneumothorax is a seldom, but it is very important to rule it out. Every patient having breast pain, having dyspnea, you have a look. And if you are a little bit trained, you see on the right side this running of the ants, the moving of pleura visceralis to pleura parietalis, and you can say rule out pneumothorax, on proceed. On the left side, at the same place, there is no running of the ants, and here's also the lung point. Seldom but important. And then once again, looking at the patient with heart failure, with cardiac congestion. These are the so frequent situation we have. And you see on the left side relatively great amount of fluid, and you give this patient adequate cardiac therapy, ACE inhibitors, beta blockers, some more, and of course diuretic therapy. And from the left picture to the right picture, it may be a time 1 week. What about 1 week? If you give him diuretic therapy, this pleural effusion will decrease, will vanish. But you will have to find the point when to decrease the dose of diuretic therapy. You know, too much diuretic therapy may harm. It decreases renal function. People are coming home from the hospital, high doses of diuretic, and you at home, you have to reduce the dose, because you kill the patients if you continue the therapy of the hospital. So how to manage it, how to titrate it, how to fine-tune this. And we have the clinical possibilities: body weight, auscultation, and then it's finished. But that's not sensitive enough for a good titration. Old patient, comorbid patient, 20 milligrams furosemide more or less. And I check these patients every week. Either they come in my clinic, or I go for house visit, and to titrate this diuretic therapy, I would not know. I do not know how I did it without sonography in this fine tuning. And we can say, if the patient themselves can do it, I have the picture from Professor Jensen last year, but it is so impressive. If the patient can do it themselves, so why shouldn't we? Why shouldn't we? And we have to do it. And this focused lung ultrasound is my most frequent used sonography approach in my clinic. And in the afternoon, we will do this. My part of practical training will be this. We look for B lines, we look for infiltrations, we look if it is symmetrical, so it might be a heart failure, or it is localized, it might be a pneumonia, it might be a pulmonary embolism perhaps, but we see there is something wrong in the lung, yes or no. And then the patient sitting, you see it's the same place as I showed you before. I look a little bit lower to the kidneys, I see the pleural effusions, and then going through the liver. I look through the liver on the right heart, the uh, um, congested liver veins, the right atrium. And so I have, in very few minutes, the sitting patient, you know, general medicine are walking in patients. So I need not every time lay them down. I can do it in sitting position, and it saves me time. You know, 100 persons, the waiting room is full, but I have to find a clear clearing of the patient. So if lung is so well seen in sonography, do we need lung auscultation anymore? Yes, we need. We need it. We want to hear the sounds, the lung ventilation, especially the wheezing and the obstruction you cannot see in sonography. At this item, I will tell you at my next presentation for emergency medicine. There I will focus on this item. So we need lung auscultation anyway. And of course, we want to see at the heart. And now, Dr. Agoston yesterday said there is a steep learning curve. And all these of you, those of you who are not so experienced, have a look at these two hearts. And if you have never done echocardiography before, look at these two hearts and find your decision. Dr. Agoston yesterday had a slide, 50 examinations, and you are relatively safe to do focused, not echocardiography. It's a different thing to do focused examination of the heart. And you see there is a normal heart function, but on the right side you see thin walls, less contraction. Okay, so, and we look at the vena cava and the hepatic veins. Are they congested or are they thin, small? On the, like on the right side, sign for right heart dilatation, overload. And once again, the question, is there a need for heart auscultation if we can see the heart so well in the sonographic approach? Yes, it is. It is because we want to hear the sounds, we want to auscultate, we want to filter these patients who need a referral to echocardiography at the specialist. And then as last example, the soft tissue swelling. You see here the patient lying with a swollen knee. We want to puncture it, we want to relieve him from the pressure, but we also want to investigate the fluid. We want to see, is there bacterial, are there crystals, and so on and so on. But before I set the needle, I want to know what is in it. Is it totally liquid, or is it not complete liquid? Nah, I had a movie here, but it doesn't work. Okay, so in every situation where I want to put in a needle or I want to cut, I look with my probe what is under the skin. So not to be surprised what I will find in the depth of the organs. And so you need it in the room where I do my surgical works. Of course, there is the probe and the look, and so abscesses and so on, you know. So I come to the end. PoCUS means we perform a study like we saw here, and we do it by the evaluating and treating clinician himself, and it helps me to answer an impactful clinical question. Therefore, PoCUS does not belong to a single specialty or field. Every person in medicine, every doctor who has a clinical question and he can form a yes-no answer when to answer this question, sonography can help him. He should use it. That's the cue, I would say. Now, we need 3 C's to ensure quality of performance. First, it is education. That's why we are here. We need courses, we need training, and after the course, Monday morning, you take the probe and start to do what you learn in the afternoon. This is the education. And then we need credentialing. Credentialing means we need a certain number of cases documented under supervision, so that there is any qualifying criteria. And finally, we need a certification from a national institution of sonography. These 3 C's we have to I don't know the word. So looking at American Medical Association says ultrasound imaging is within the scope of practice of appropriately trained physicians. So we should do it, but we should train and we should to ensure the 3 C's. Looking at the sonographic companies in Austria, Switzerland, and Germany, they have a combined concept of stepwise certification, stepwise. And the basic step in this ÖGUM, DEGAM, ESGUM curriculum is called emergency medicine. And you see the hours of needed education and the number of cases you have under supervision and documented with a final teaching. We can discuss these numbers, and this will be the work for research. What are the right numbers for credentialing and for, but this can be a proposal, and it is practiced now in the German-speaking countries of Europe. There are a wide range of uses, and now I want to suggest, and I want to say to you, start now and gain your experience. Start with simple, with easy to perform techniques. As I told you, skin, soft tissue, effusions, pelvis and bladder obstructions, fluid against parenchyma. That's the very impactful diagnosis, and is gratifying. You are happy. You see something, and the patient is happy because you can help him very quickly. Then go to abdomen, fluid in the abdomen, hydronephrosis, and of course the chest. The chest is a very gratifying region for sonography, because you have a steep learning curve. Last year, Professor Jensen told us the study only few examinations, and you are relatively good able to do this distinction. I want to enforce you to start. And now I'm very happy. Also, these congresses promoted the making of a paper of Wonka of the use on point of care ultrasound in primary care. Like Professor Shlomo Winker said, the vocational policy, there are different stakeholders with different interests, and we need a strong paper to tell the position. It is, we could say, like in the Bible, at the beginning was the Word. And this should be the word for sonography, and then comes the practice. And I thank you for your attention.
Mikael. Thank you so much to the organizing team for inviting me, and I'm very happy and very proud to be part of this very successful, impressive meeting. And I would like to thank you on behalf of Fsum that you have done this effort to teach family physicians, general practitioners in ultrasound. It is supported by Fsum, and therefore I'm here, and therefore other Fsum members and former presidents, for example, also to support this Fsum and EUROSON school. You have heard a very interesting clinical and practical lecture by Dr. Sigmund. Now we have a little bit more dry topic on guidelines of Fsum, but I hope I can tell you some interesting things. These are my conflicts of interest, and I would start with some comments on Fsum. What is Fsum? What we would like to do, and what is the history of Fsum. In this year we had a 50th anniversary of the European Federation of Societies in Ultrasound in Medicine and Biology, and I would like to take 10 minutes to tell you something on the roots of ultrasound societies in Europe. We would like to call us the European ultrasound family, and why we do that? Because I think a family has common genes, which in our case of Fsum is mainly the gene that encodes the love for ultrasound. And very important is that each generation of ultrasound practitioners in a family inherits experiences, achievements, of course also mistakes, and their values of previous generations. And members of a family stay close together, especially in difficult times as we have now, of course. They help each other and they solve their conflicts with mutual respect and with the knowledge that despite all our difference we may have, we belong together. And this is why we have such a long history of Fsum. All this has sustained and held Fsum together for 5 decades. And I'm very happy that you are also part of this history. Some comments on the history. It is very interesting, I think, that it has been a very small group of people performing ultrasound, ophthalmologists, which had open eyes for multidisciplinary clinical ultrasound. And on the first meeting of an international society of ophthalmologists devoted to ultrasound in 1964, which was held in Berlin, in my hometown, formerly East Berlin, at the famous hospital Charité. There was a first symposium of this ultrasound group in ophthalmology, and they founded an organization which still exists, the Societas Internationale de Diagnostica Ultrasonica in Ophthalmologica. They choose this Latin term because they wanted to say we are an international group, we are an international effort, and we are non-political. It was in East Berlin at this time. And they met again in the Czechoslovakian Republic in 1967 in very difficult political times, a lot of tensions between the Eastern and the Western Bloc. And in 1969, this group has grown, and 190 lectures were registered for the third CIDU meeting. And interestingly, only 48 came from ophthalmology and all the others from other specialties, cardiology, internal medicine, and neurology. And the group decided that they wanted to go to the Vienna Hofburg for the Congress, and they need more than 300 attendants. And therefore, they decided they have a lot of input, not only from ophthalmology. They want to go to the famous Hofburg here in Vienna. They expand CIDU to be the first World Congress on ultrasound diagnostics. And in his opening speech, Professor Böck, an ophthalmologist and president of this Congress, said, so successful has CIDU been that the parent CIDU threatens to be swamped by this larger child it has so generously conceived and endowed. And indeed, at this large Congress, the first World Congress on Ultrasonics, Diagnostics and Medicine, there were more topics not related to ophthalmology, but to the other fields of clinical medicine. And this was a very great success and was a birthday of all European national societies, the initial spark for the foundation, for example, of the East German and the West German ultrasound group at this time, the Swiss working group on ultrasonics. Here you see the former president Hans-Rudi Müller, the British group, and all the others, for example, also in Hungary. That means in East and in West Europe, there were some groups interested in ultrasound, not real societies, some interest groups and so on, but they were initiated by the first World Congress on ultrasound. And at this first World Congress of ultrasound, it was decided to form a group from these European interest groups to discuss the possible formation of a European federation. And the Dutch neurologist Marinus de Vlieger was elected chairman of this group. And this effort was successful. And in Basel, in Switzerland, in February 1972, at the fourth annual meeting of the Swiss Society for Ultrasound in Medicine, the EFSUMB, the European Federation for Ultrasound in Medicine of Societies for Ultrasound in Medicine and Biology, was founded, and Markus de Vlieger was the first president of this organization. And the contract, the constitution, was signed by specialists from various disciplines of medicine. And interestingly, there were two treasurers because there was no exchange of currencies between the Eastern and the Western Bloc, and therefore they had one for dollars and Deutsche Mark and one for rubles and Mark der Deutschen Demokratischen Republik and so on. And all this time we had wise leaders. You see here this very nice picture from another World Congress of Ultrasound in Medicine in Florence in 2000. Professor Luigi Bolondi, here on the left side, in a costume of an ancient doctor, was one of the wisest doctors, and there's another picture showing him as his last XP meeting with a crown on his head. If you are interested in history of ultrasound, in the history of the European Federation of Societies for Ultrasound in Medicine and Biology, then you can look at this editorial in Ultrasound in Medicine published this year. And in parallel, we had a publication in the Romanian Journal for Ultrasound, Medical Ultrasound, and this is related rather to the history of ultrasound as a clinical specialty from its birth to date. And we had a small booklet on 50 years of EFSUMB. What we stand for. Ultrasound has changed a lot in these 5 decades and now has become, you have heard it from Dr. Sigmund, on the one hand, a complex, high-end, multi-parametric imaging method, and on the other hand, a bedside clinical examination with handheld devices. 2 parts, 2 sides of one coin. But other imaging modalities are also taking a dynamic development, and the need of ultrasound practitioners are changing and diversifying. And therefore it takes the courage to question the familiar, to shake the dust of history from our closest, to give fresh ideas a chance, and to set new impulses. And I think we must take the different needs of ultrasound practitioners, for example, as you are in general medicine and families and as family physicians, and of the different ultrasound societies across Europe into account, considering that not all who practice ultrasound are members of our national interdisciplinary big societies. They are, for example, members of EUROSON. We have to respect this. In this year, we had a debate, and in the last year, on the new constitution of Fsum, and we wanted to reflect this idea that we have to be more open to new developments. And in our new constitution, we had something changed. For example, we are aiming for transparency, diversity, and equality in our European ultrasound family. We don't have a sonographer in our boards, but we will have. We are committed to making ultrasound available to all who are qualified to use it medically. And of course, we want to have GPs and family physicians also as a part of our committees, of our guideline groups, because it is for us very important to provide high quality ultrasound guidelines, education and training. And we are committed to democratization of ultrasound. That means we would like to have ultrasound as a handheld or as a high-end machine examination anywhere, at any time, for anyone trained and for any good indication. And that involves not only physicians, in my opinion. That also involves specialized nurses, for example. And we stand for high-quality standards of ultrasound regardless of who performs the ultrasound scan. I remember to a very famous and discussed paper of Professor Paul Cito, and I think it was Hazel Edwards as a co-author, discussing this very important topic. Now to my real topic, Guidelines Project. This is our most important success story. Contrast-enhanced ultrasound guidelines, starting with liver guidelines, and now we had in 2020 the fourth iteration of the oldest and most famous Fsum guideline on contrast-enhanced ultrasound in the liver. We did it together with the with BIFUM and the other BIFUM member federations, but it is our heritage as Fsum because we started in 2004. And this is very successful, but it's also part of a problem I want to discuss a little bit. Because if you perform in your family practice ultrasound, you don't, in most cases, you will not have the opportunity to perform contrast-enhanced ultrasound. That means we have a lot of very, very good, high-quality guidelines, but they are related to the one side of the coin, to the highly specialized ultrasound coin. And I think we have to do more for the other side of the coin, not the back side. It is equal side, and that is PoCUS, that is simple daily practice ultrasound, as has been shown in the former lecture. The first choice guideline had more than 600 citations, followed by 2008, the first update with more than 1,000 citations, and then the third in 2013, I think is the most cited guideline from Fsum with more than 1,300 citations, and this is an amazing success story also for the journal Ultraschall in der Medizin, European Journal of Ultrasound. And again, in 2012, we had 1,330 citations with the non-hepatic applications, because we saw that this is not only the liver in which we can perform contrast-enhanced ultrasound. Another success story are the elastography guidelines. And this is maybe a little bit closer to family medicine, because I have learned that you are very interested in the thyroid, and elastography may be part of a good thyroid nodule examination. And this is part of this first elastography guidelines, which were very well cited also in the following literature, and were followed by elastography guidelines on liver and non-liver applications in the years 2017 and 2019. Then we had an interesting guideline series, the first series we did on interventional ultrasound, and you may be interested in some parts of this guideline series. And together these 6 parts had 867 citations, and I've only shown 2. One which is not so interesting for you, but I was an author on interventional ultrasound in endoscopic ultrasound. But the second and the first part may be of interest for you. Also the sixth part on vascular access, the first part on general aspects, and the second part on diagnostics with interventional ultrasound. And maybe also for you of interest is a guideline series and position paper series on gastrointestinal ultrasound, the seventh part of this guideline project of EFSUMB, which was led by a former president, Professor Helge Gilja from Norway, was published in 2021. And this was on functional disorders of the gastrointestinal tract. And I think that in your practice, Dr. Sigmund, maybe that 20% of your patients have functional disorders of the gastrointestinal tract. I cannot comment now how to use ultrasound in this setting, but I would come back to the question of time. In my opinion, ultrasound performed as POCUS, not as a comprehensive ultrasound examination, saves time because it is a dialogical examination. You look not only on the transducer and on the screen, you speak to the patients and the patient will answer and the patient will see what you think and what you see in your eyes. And this will bring a very close relation within minutes between the patient and between the doctor. And this is important and this is a chance and it saves time, definitely. Then coming back to the guidelines, we had a position paper again on contrast-enhanced ultrasound for renal cyst. May be interesting because most patients will be sent to CT for classification. This is a tradition, this is a golden standard, but not the reference standard. It is from tradition and we can use ultrasound with contrast enhancement for a very exact classification of renal cyst. And also for you interesting may be our last achievement with a guidelines project led by Dana Fodor from Romania on musculoskeletal ultrasound. 2 papers on extra-articular and joint pathologies was published in 2021 and 2022. And this is a last guideline or position paper project, which is only at its beginning. We now published a paper on professional standards in medical ultrasound, and this should be followed by a series of further papers which will describe the quality standards in several disciplines of ultrasound. And in this general first paper, you can see this is exactly the situation Dr. Sigmund has in his practice. You need a good place, but you need not a large room. But you need enough place. And if you perform, for example, in a hospital interventions, you need some more place for equipment and so on. But we commented also on medical ultrasound hygiene, on structure of medical ultrasound examinations, documentations, reporting, and data management. And for example, this may be also of interest for you, the mandatory content of ultrasound examination reports. But this is more for comprehensive ultrasound. I think POCUS don't need a 1 or 2 page report. It may be 1 sentence. There's a cyst of the left kidney, no other findings, or fluid in the lung, 20 B lines per field or so. And we want to expand this professional standards project, and I invite you to take part in this efforts. Is a long way to go and collaboration is needed. Some words on quality of our guidelines. There was some critique from other societies that our guidelines no longer meet the highest methodological standards, and therefore we adopted a new guideline strategy. And we decided, because this is really time consuming, not a POCUS examination, but to prepare high quality guideline papers, to join our efforts with VIENNA, with the other federations for ultrasound in medicine and biology, and of course with societies, with partner societies as Ulricus. And we have to get a more broad impact. Now we have good guidelines for ultrasound practitioners, but I think, for example, the gastrointestinal guidelines are well known by specialists in ultrasound performing gastrointestinal ultrasound. They may be known to some gastroenterologists, but not to all. And they are, I think, not well known in the community of GPs having patients with inflammatory bowel disease, but they can use this. And therefore, we have to gain more impact. And this is one important aim of our efforts. And therefore, we decided, I come back to this, to expand the reach of our guidelines. And we started with in cooperation with the United European Gastroenterology Society, which has a lot of members, and they have a very good interactive guideline app, which is free. You can download this, which currently contains 27 guidelines, and 2 now are from Fsum and has been downloaded by 20,000 users. And we will launch this year our own ultrasound guideline app. Our newest guideline projects are POCUS guidelines. They are more related to emergency medicine. The lead author is Bob Jarman, and the first part on common heart and pulmonary applications is accepted in May 2022 and will be published hopefully in one of the next issues and online, of course. And a very ambitious project is to write multi-parametric ultrasound guidelines for the thyroid, for breast, testis, pancreas, and then in future also for the liver. And we start with improved methodology, with like a meta-analysis starting, and we pay rather money now for librarians helping us to make the literature research, than for meetings in very good hotels, for example, in London or Copenhagen. Now we meet at Zoom and pay the money for the librarians. Why not common projects with, on guidelines and position papers with Euvecus? I have heard for the first time now of your project of a position paper on the role of POCUS in family and general practice medicine, and we as Fsum would be able to endorse such a guideline or position paper, and we are also ready, as we did now with the European Federation of Emergency Medicine, to make a common position paper or a common guideline, for example, on the quality standards of POCUS in family medicine or in palliative medicine. And I think it could be a good idea also to make a survey on the role of ultrasound in family medicine in Europe. I'm very sure that there are different approaches in different countries. There are different problems, and there are interesting solutions to solve these problems, and we don't know from each other how to help us together. And I think there's a big room for improvement. And I would like to thank you for your attention, and I hope that we are now preparing the program, that we find enough room for family physicians and GPs for special ultrasound sections or sessions within the program of the EUROSON 2023. Thank you so much.
I want to present you our successful and the results of the Thyro screen cross-border project, the risk stratification of the thyroid pathology, the use of artificial intelligence in thyroid ultrasound screening in primary care. We know the thyroid ultrasound have a very good sensitivity, but the conventional ultrasonography have the sensitivity 87% and specificity 93%. But if you apply the multimodal ultrasonography with the Doppler color and with the elastography, the strain elastography, you can increase the sensitivity till 96% and the specificity till 95%. It's very important because you can put the diagnosis. And till now, we have the indication for the thyroid ultrasound following the American Association of Clinical Endocrinologists. And they said, it's a very good method to confirm presence of the thyroid nodules, to characterize the thyroid nodules, to make a differentiation between the benign and malignant thyroid masses based on the sonographic appearance, to differentiate between thyroid nodules and other cervical masses, and also to evaluate diffuse and in thyroid parenchyma and detect post-operative residual or recurrent tumor in thyroid bed. And also you can screen high-risk patients for the thyroid malignancy as in our project, and to guide diagnosis for the fine needle aspiration cytology and when to do the fine needle aspiration cytology. What is the Thyro screen project? As a definition, a screening is assessment of the population at risk for thyroid cancer to diagnose the disease and the early stage without symptoms. We made a targeted ultrasound screening and addressed only to a certain group of the population who present the risk factors for a thyroid pathology identified through the patient inclusion questionnaire. And this project was applied in Romania and in Serbia, was a cross-border cooperation program, interregio, between Romania and Serbia, and it's financed by EU and through the instrument for the pre-access. And the name of the project was the Common Approaches for the Screening and the Early Diagnosis of the Treatment of Thyroid Cancer in the Population of in the partner areas. And what was the reason to start this project? Because you can see between age 49 to the woman, the thyroid is the second place, like prevalence in the cancer of thyroid is the second place to these ages. What was the purpose of the thyroid ultrasound screening? Did you know that about 38% in our west part of Romania and east part of Serbia, we had the 40 till 40% of the high-risk population for thyroid diseases. The thyroid cancer can be present in up to 3% on the high-risk population. When was diagnosed in the early stage, the thyroid cancer is curable almost 98% of the cases. But the late diagnosis could reduce the 5-year survival to 37%, which is very low. And you know, in recent decades, after the nuclear accident at the Chernobyl, we observe a clear increase over 10 times of the thyroid diseases, predominantly because of multinodal goiter and autoimmune thyroiditis. The prevalence of malignant thyroid nodules are growing, mostly be 80% papillary microcarcinoma. We tried to analyze this using Doppler ultrasound, and then we made the strain elastography to identify the tumor stiffness. The Doppler ultrasound used as a screening method can diagnose both the diffuse thyroid disorders and also the focal lesions of the thyroid, and with benign and malignant tumors. This project has 3 stages. The first step was to develop a computerized diagnosis algorithm used to stratify the risk of thyroid pathology. The ultrasound based. It set the optimum time to achieve a thyroid biopsy or finding the aspiration cytology. We have used the latest international classification as well as the scoring made by us correlated with the histopathological results. The second stage included a targeted thyroid screening in a population with high risk and statistically significant. And finally, this was a monocentric study. And finally, we are launching the interdisciplinary multi-center ultrasound screening in partners areas. And our question was why, how, and whom to do the thyroid ultrasound screening program. And we started to make a design, a study design, when we starting with the population, with the large population in the areas, in the west part of Romania and east part of Serbia. And we made a questionnaire, and we distribute this questionnaire to 20,000 patients. And if the questionnaire was with the positive response for the patient, was an electronic questionnaire. And if the patient was with the positive response, the patient was referred to 20 family physician who was trained in ultrasonography, in the thyroid ultrasonography. And they make an ultrasound examination of the thyroid with the help of the artificial intelligence. They put all the data in an algorithm, in a computerized algorithm diagnosis, and then if the result was in the risk stratification with the help of 3 European and international score risk, and if the score risk was higher, the patients was referred to the specialist, to the endocrinology specialist, and the endocrinology specialist made the finding the aspiration cytology, and if the patient was positive, was referred to oncologist and to chirurgy. And then we have the results of histopathological, and we compare the results of histopathological with our computerized algorithm. This was very important because we find a very good accuracy of our program. And what is the main purpose? It was to make an early diagnosis of diffuse and focal thyroid lesion, and also to make an early diagnosis of thyroid cancer. This questionnaire we launched to the population, it was based on the hereditary antecedent, to the medical history, and the clinical examination. We have this epidemiological questionnaire to online questionnaire also, and we refer to 20,000 patients, and containing some inclusion criteria. And finally, this questionnaire was distributed by the family doctors in our part of country. We have more than 400 doctors, family physicians, who distribute this questionnaire, and also the patient could access directly the like a self-assessment of the patient. This was some question in our questionnaire, and we have some question like a history of thyroid cancer, exposure to ionizing radiation, exposure to chemical and biological risk factor, the prior hymethyroidectomy, and presence of diabetes or other autoimmune diseases, the deficient and excess of dietary iodine or use of the drugs who contain iodine, and so on. And the clinical examination, we have some questions like the diffuse or localized swelling of the anterior cervical region of the neck, the firm or irregular fixed thyroid nodule, and so on. And we have these results with all these questions in the electronic questionnaire. and the patient was automatically included in our screening. We have also the exclusion criteria for this screening, and what you can do with the ultrasound thyroid, what evaluation you can obtain. You can find if the gland, you can make the gland identification with 2 lobes and 1 isthmus, the thyroid volume measurements, the evaluation of echogenicity, the parenchymal vascularization degree, the presence of nodule, vascularization of the nodule, and the stiffness of the nodule. And this screening was very important. The thyroid ultrasound screening performed finally to 6,386 patients, apparently healthy adults with oncological risk factors, age over 20 years, followed for 2 years by our team. To the patient aged between 20 and 40 years, we have conducted an ultrasound screening every 2 years and over 40 years annually. The objective was the diagnosis and early diagnosis of treatment of the both diffuse and focal thyroid lesion by ultrasound screening to the high-risk patients. And the research question, how can we improve early diagnosis and differentiation of these thyroid diseases by GPs? And our aim was to assess the applicability of both Doppler and strain elastography and in differentiation benign versus malignant tumors. And we want to design a diagnosis scoring scheme system and computerized algorithm for performance thyroid ultrasonography. Like our third eye, as I said. We use the multi-parametric thyroid ultrasound with the power and Doppler, duplex, and triplex ultrasound, the strain elastography. We have our cutoff of strain ratio for malignant thyroid tumors over 2.5. And also we did a malignant ultrasound score. And the gold method remains histopathological results or cytological results, of course. This is some cases. This is autoimmune thyroiditis, chronic thyroiditis Hashimoto. This is a focal lesion with a nodule, but a benign nodule with isoechoic aspects. And let's see, let's speak about our plans and standardization in this screening. We try to put the patient in the supine position, and also we use all same ultrasound devices. All 20 doctors has the same ultrasound devices, the same ultrasound software, and we preset the thyroid and the thyroid settings for this and frequency. We have the 12 megahertz in linear probe, and we use Doppler, elastography, conventional ultrasonography for this, and we use sagittal and the transversal section in this study. We have a protocol to use the ultrasound, and this is the protocol, our protocol, and ultrasound evaluation and what to look in this screening. We look to the thyroid gland identification, the thyroid gland volume measurements, the echogenicity of the evaluation, the homogeneity evaluation, the focal, the diffuse lesion characterization, the focal diffuse parenchyma vascularization, the focal diffuse parenchyma stiffness, and regional lymph nodes evaluation in our ultrasound screening. This was the section we used, and we learned all this family physician with the transversal and longitudinal section standardized. And also we put on this picture all the nodule when we will find the nodule where is in the superior, in the middle, or the inferior the localization in the thyroid. We find a lot of pathology. As you know, we have diffuse and focal thyroid diseases, and we try to find the thyroiditis, the acute, the subacute, the chronic autoimmune thyroiditis, the thyroid malformation, the macronodular goiter, the Graves' disease, and also some non-thyroid formation. And if we speak about the focal lesion, we find the benign nodules like hyperplastic nodules, follicular adenoma, Hashimoto thyroiditis nodules, and malign tumors as papillary carcinoma in 80%, follicular carcinoma in 70%, and medullary carcinoma in 4%, and less was the Hartle cell carcinoma, and let's see anaplastic thyroid cancer, who is very dangerous. And our ultrasonographic description must contain the thyroid volume, the echogenicity, is isoechoic or is hyperechogenic, or hyperechoic is hypoechoic, and echo structure homogeneous or unhomogeneous with micronodular, macronodular, and also the parenchymal vascularity in the ripples Doppler increase or decrease. And you can see here the Hashimoto thyroiditis with the higher vascularity of the thyroid, the entering parenchymal thyroid, and enlarge of the thyroid. And also in elastography you can observe here the hard stiffness of the thyroid because it's a chronic thyroiditis. And we did this intelligent algorithm, and we launched this software in the WONCA Congress from Copenhagen. And this is our intelligent software and algorithm. And now we try to make a step forward, and we try to make an auto detection of lesion in the thyroid, and to put all this described lesion in the automatically in this software. Just the family physician must to put the probe on the neck of the patient and to make an auto detection of the lesion, of the focal lesion, if we could. And this is the software. You must put all the data you obtain in the diffuse data, and also if you find the focal lesion, you must put the data about the focal lesion, if the lesion is hypoechoic, hyperechoic, and so on. And we use this ACRI thyroid score. We use the EU thyroid score. We use our scores, and also we use the histopathological results in our software, and we compare all the data with the histopathological as the gold standard method. And you can find here another cases of multinodular goiter and also with the Hashimoto. This is was a based of or Graves' disease. And if you find the ultrasonographical thyroid nodules, you make these ultrasonographic features about the nodule. Is solid or is cystic? Is echo structure with homogeneity or in unhomogeneous? The shape, the contour, the calcification, the vascularization in type 1 with no flow within the nodule, with type 2 with perinodal arterial flow, and type 3 with intranodular flow. And also the presence of the cervical and supraclavicular lymph nodes. And we use the nodule volumes and with ellipsoid formula, and it's very important to make this examination in dynamics after 3 months to see if the nodule is enlarged or not. And our software automatically detects this and can do this comparison between the first examination and the second examination. We try to use this echogenicity of the nodule. Is hypoechoic, is mild or markedly hypoechoic, is isoechoic, is hyperechoic nodule, and the vascularization is type 2, type 3 with the enter vascularization of the nodule. And we have some nice image about a cyst. A colloidal cyst of the thyroid is the benign nodule, is not a problem. And we try to look into the cyst to find if you have some tumors, and also you put the elastography to see the stiffness of the nodule. And this is a spongiform nodule, is also a benign nodule. In the elastography you can see is with the soft stiffness and with the peripheral vascularization of the nodule. Also, a benign nodule is an isoechoic nodule in the round shape, and when you put the color Doppler, you can find the internal vascularization, and when you put the elastography, the strain elastography, you can find the hard stiffness, and we made this strain ratio between the nodule and the normal tissue, and you can find here a higher strain ratio, more than 2.5. And with the conventional was the aspect of the benign nodule, but if you put the strain elastography, you can find here the hard stiffness of the nodule with the vascularization, the type 3 vascularization, and was a microcarcinoma, a micropapillar carcinoma. And you can see, you can increase the accuracy of the diagnosis if you use the conventional, the color Doppler, and also the elastography, because we have a lot of information about this nodule. And you must put all together. You can observe here some microcalcification, and also is an extra thyroid extension of this nodule, is a large nodule with the microcalcification, and in the Thyroid score is Thyroid 4B, and we speak about this later. This is the strain rate, the hard stiffness of the nodule, and with the extra thyroid extension. Also, this is the vascularization, entire nodule vascularization, and different types of nodules. And another microcarcinoma, micropapillar carcinoma, and you can see the hard stiffness of the tumor. You can see the higher vascularization entirely to the nodule. Another nice image with the malignant tumors with the hard stiffness. You can see here the nodule with the hard stiffness with the color blue coded, and also with the entire vascularization, type 3 vascularization of the nodule, and another malignant tumors. And this is the stages we use in well-differentiated carcinoma when you have the stage 1, 2, and 3, and 4. These stages was calculated automatically if you have the positive diagnosis in histopathological or in cytological suspicion. And we can now we know if you make an ultrasound examination of the papillary thyroid carcinoma, you have a heterogeneous hypoechoic nodule with the irregular shape with the characteristic microcalcification in the color Doppler is not so useful to diagnose papillary cancers. And we have some nice image. This is the nodule. It was a micropapillar carcinoma with the microcalcification, with the hard stiffness, and you can see the vascularization is the type 2. And also another image in the longitudinal section with the vascularization and also the hard stiffness with the color coded blue of the tumor of the carcinoma. In the follicular thyroid carcinoma, who is just 10% of the thyroid cancers, to the ultrasound you obtain the follicular carcinoma similar to follicular adenoma. It's not very good differentiation. But adenoma is oval to round, is echoic, and the carcinoma has the irregular margins with thick halo and chaotic vessels. In the Doppler, with the high velocity pulsatile flow penetrating tumor, you can see this high vascularization in the follicular carcinoma. And also this is a lesion, a follicular carcinoma, and you can observe here is a necrosis, a tumor necrosis in the central of the tumor. And with the high vascularization and with the high hard stiffness, and the delimitation is not very well to the contour and to the margins. This is the tumor with the extra thyroid extension with the central necrosis, with the hard stiffness, as I said. Another cases of the follicular carcinoma with the high vascularization and entire the nodule. And you can observe this is the hard stiffness of the tumor with the strain ratio increased between more than 2.5. In the medullary thyroid carcinoma, in the ultrasound you can observe the solid hypoechoic nodule with central coarse calcification. Is very important for the medullary thyroid carcinoma. In the Doppler you can have high vascularization of the nodule, and you can find here a nodule with the high vascularization, peripheral and internal, and also with the microcalcification, the presence of microcalcification, and you can observe with the hard stiffness of the tumor, and here you can observe a coarse calcification with the posterior shadow of the nodule. This is the nodule. This is the second nodule in the thyroid. And you can observe here the posterior shadow and the coarse calcification, central coarse calcification, who is specific for the medullary carcinoma, thyroid carcinoma. Nice image. I think here is very well defined this posterior shadow and the coarse calcification of the nodule. And you can put the diagnosis when you see this pattern. You can think about the medullary carcinoma of the thyroid as a family physician, of course. And of course, we refer the patient to the specialist, to the endocrinologist. But it's better to do the normal image to be detected by the family physician in early stage. We use the Thyroid classification, is a personalized management with risk stratification in 5 categories, and the minimum unnecessary fine needle aspiration cytology is in the thyroid 2, 3. We starting to refer to the endocrinologist in the stage thyroid 4. And this was the history of thyroid scores. First thyroid scores was defined by the Horvath, and the second was the Korean thyroids. The third was the British Thyroid Association. In 2016, American Thyroid Association adopted this American thyroid scores and A3 thyroids. And also in 2018, the EU thyroids appear. We use all this classification. We try to put all the data to have and to compare these scales between this model of risk stratification, because it's very important for us as a family physician when to refer the patient to the endocrinologist to make a fine needle aspiration cytology. In the A3 lexicon, we use the shape, the margins, and you can see here what is the composition of the tumor, what is the echogenicity, is echoic, hypoechoic, what is the shape of the nodule, what is the size, more taller than wide, more wider than tall, the margins and the extension, extra-thyroid extension, and the presence of microcalcification and echogenical fault. This is the microcalcification and eggshell calcification in our studies, and the microcalcification and eggshell, and you can observe this in the heart stiffness. And this is a tumor with extra thyroid extension with not higher vascularization, just peripheral vascularization, but with the heart stiffness in the increase of the strain ratio. And to differentiate diagnosis benign versus malign focal lesion, you need 8 parameters: the internal consistency, the echogenicity, the margins, the surrounding halo, the calcification, the vascularization, the presence or absence of the normal lymph nodes, the tumor stiffness, of course. And the ultrasound pattern, like a concept of malignancy, must be a solid with a solid tumor with is a hypoechogenic or marked hypoechogenic with the nodule shape more taller than wide, irregular margins, lobulate, extrathyroidal extension, and absence of the halo, and microcalcification or punctate echogenicity, and peri and intranodular vascularization, and the presence of the cervical adenopathy with heart stiffness, of course. This is the pattern of the tumor, of the malign tumor of the thyroid. And you can see another microcarcinoma, follicular carcinoma with high vascularization, with the heart stiffness, with the tumor central necrosis, with the higher vascularization. This is the acere thyroid scores we use. This is the EU thyroid score we use in our software, in artificial software, and we use all this data to make a risk stratification. This is the spectrum of thyroid nodules categorization, and according to the thyroid score, you can see here a cyst is score 2 or 3. If you have a solid tumor, you can have this 4A or 4B, 4C, because you have the presence of microcalcification and so on. This is the thyroid. But we use our own score, and we introduce in this score, in the previous scores, the presence of vascularization in our classification and the presence of elastography of the stiffness of the tumor, and we make our own scores. This is our own scores we use, and we publish this in our book. You can find outside this atlas, and this is our risk score. We use it in our software. And this is the thyroid classification, and we explore these nodules till 3 or 6 months. And if the nodule grow in dynamics more than 20%, is a very risk category, high risk category. And we use also the EFSUMB Elastography Guidelines, and they said the ultrasound elastography of the thyroid should be used as a part of nodule characterization, particularly with use of semi-quantitative methods. And we use this REGO score. It's very interesting. If you are in one score, you have the soft stiffness in entire the nodule. If you have the score 5, you have the hard stiffness indicating in the nodule in extranodular hard stiffness. And you can see here some nice image with the malignant tumors, with the microcarcinoma, papillary microcarcinoma, with the hard stiffness, with the high vascularization, mixed with the extrathyroidal extension of the nodule, extrathyroidal extension of the nodule, with the hard stiffness, with nice image, and we use minimum 6 determination of the strain ratio to not have an error of our diagnosis in the longitudinal, in the transversal section. This is the microcalcification of the cyst, microcalcification, and was, I think, a tumor with eggshell calcification, but you can see this hard stiffness, but it's very hard to say the hard stiffness is because it's the eggshell or it is the nodule. And we refer to the specialist and make the fine needle aspiration. This is the malignant tumor with the higher vascularization entire the nodule. And this is the cyst. And we went to do the fine needle aspiration and biopsy, and we use all these scores in our software and try to have a protocol for the family physician what to do with your patient if you have a nodule. This is the micropapillary carcinoma with the microcalcification and also coarse calcification. You can see here. I try to be short now. Our result was very interesting. We made initial some descriptive statistics. We analyzed data with the sensibility, specificity, and accuracy of the screening. We compare statistical analysis and make some differential diagnosis versus malignant versus benign, and compare with the results of the histopathological. Finally, we compared all these data. We made ROC curve analysis, ANOVA analysis, and so on, statistical analysis to see what was our results. We have a lot of patients. As I said, 35% of our patient was with diffuse and focal lesion, and you can find here a lot of data, statistical data, and the sensibility is very interesting. With our software and with this multimodal multi-parametrical ultrasound of the thyroid, we had a very good sensitivity, 96%, very good specificity, and also with a very good accuracy of 96%, was a multidisciplinary screening between the primary healthcare, secondary healthcare, and tertiary healthcare, and diagnosis was established for all these steps. This is our results. You can see our software, our scores, and also the ANOVA and the statistical analysis, our ROC statistical analysis, and some image with the hard stiffness tumor, with the high vascularity nodule, And in conclusion, ultrasonography proved to be a very efficient method with a high value in thyroid screening with a very good accuracy of the early detection of diffuse disease. And Doppler ultrasound has a high value in thyroid screening. And strain elastography bring us important details in the differential diagnosis of benign versus malign. This is the take-home messages. If you find an inhomogeneous solid tumor with the marked hypoechogenicity, with the irregular margins, speculate, or the presence of microcalcification, with the oval shape more taller than wide, and central and peripheral tumor vascularization, type 3 vascularization, and the presence of cervical lymph nodes, you must be very to be aware. And this is like a sample in the pandemic, because the project was starting in the pandemic, in the full pandemic, but during 2 years, and we finished this project with very good results. Thank you.
All right. Thank you, Mr. Jakob, for the introduction. Good morning, everyone. It's a pleasure to be here today to meet you all. My name is Maria Luisa Steines, and today I would like to give you a short presentation about the Liamet company, as it is already a tradition for us to be present at this important event in order to support EUVECUS and Mr. Mihai Jakob as reliable partners regarding many projects and medical events that we took part in together throughout the time. So, Liamet has reached 23 years of activity this year. Our core business activities are importing, selling, and offering maintenance for a wide range of medical devices, including ultrasound machines, of course. Our headquarters is established in the center of Romania, in Brașov, and currently we are a team of nearly 100 people who try to support the best medical act in Romania. At this moment, we import medical devices from several countries in Europe and Asia, from companies, of course, recognized for the quality of their products and services. As about our clients, we delivered medical devices to more than 7,000 clients from both public and private health system in Romania, and we received positive feedback for all our products, and I think that this is a strong proof that we are successfully fulfilling our mission. As you can see, our portfolio covers a large amount of medical specialties such as ultrasonography, neurophysiology, cardiology, surgery, ENT, ICU, and so on. Maybe the key point that makes Liamet the best choice for medical devices is the maintenance services that we offer to our clients. They are very accessible and always of a high quality, as our colleagues are engineers authorized and certified by the manufacturing partner companies. Now, I would like to focus on our business partnership with Sonoscape, as Liamet is the exclusive distributor for their medical devices in Romania. Our partnership with Sonoscape started 15 years ago, and we are continuously developing our collaboration as reliable partners. Throughout time, we helped each other and developed together, as Sonoscape evolved step by step too, being always updated to the latest trends. A little bit about Sonoscape. Well, the headquarters are in Shenzhen, China. Shenzhen is a leading global technology center and China's first special economic zone. And of course, the company, very important to mention this, was founded in 2002. The starting products of Sonoscape were the ultrasound machines. And actually the founder created the first portable color Doppler ultrasound system. After this, Sonoscape extended their portfolio by introducing endoscopic products in 2012. First, it was about the flexible endoscopy system and then the rigid one. As you can see, Sonoscape is present all over the world, mainly in Europe, Asia, and USA. And they also have several service centers in Europe, Asia, and USA. As I have already mentioned, Sonoscape's portfolio contains ultrasonography and endoscopy systems. Now I would like to focus more on the ultrasonography field. Regarding this area, Sonoscape is among the top 10 best manufacturers all over the world. And as you can see, they have a large portfolio of both stationary and portable ultrasound machines. Each of them are different because they are operated differently and because of their features and functions. I think that most of you could test them yesterday and can also test them today in the hands-on part. All right, finally, I will make a short summary of the functions that are available for both the types of ultrasound machines. The first one would be the elastography, which evaluates the hardness of nodal lesions. Then we talk about the CUS, which is very important for the details of the deep structures, as well as the microvascularization, because they are contrasted and emphasized very good. Then we talk about the micro F. This is a special function for visualization of microvascularized structures, having high spatial and sensitivity and resolution. About the S-thyroid, this is another special function. It can automatically define the lesion boundaries and generate a report regarding the features of the suspicious lesion. The VISE needle, this provides increased needle visibility to provide safety and accuracy to a series of interventions such as nerve blocks, punctures, and biopsies. And so on. All right, this was the presentation. Thank you for your attention. And I would like to mention that we always guide our activity with our motto, let your smile change the world, but don't let the world change your smile, because we are very passionate about what we do and we want to transmit this to our clients too. Thank you.